I'll be presenting on patient-reported outcome measures and specifically focusing on ICHOM, standard set of indicators, and DHSV's collaboration with ICHOM and how we are using ICHOM data as part of our proof of concept value-based healthcare initiative. And I will also draw on the principles of value-based healthcare and how it applies when we collect the data and how important it is to measure outcomes from a patient perspective. Now, you would have heard about value equation from most of the speakers who spoke before me, but just reiterating what value is. Now, value is improving the outcome from a patient perspective and what matters to them. As we stand, we are not very good at collecting outcomes. Basically, we collect outputs and also inputs. So output is more about what we produce and the organizational activities. We use output to quantify, traditionally, to quantify health services. And it's a very important source of data. However, we cannot derive information to achieve value, and also it doesn't show us how we have improved the patient health outcomes. And inputs are resources to produce the outputs. So when it comes to outcome, it is important to understand it is from a patient perspective, but it is important that the clinician also understand that clinical perspective is important to support the decision making. When it comes to cost, the numerator of the value equation, it is not about cutting cost. It is more about how efficiently and how effectively we can deliver the outcomes, and that's very important to understand. And we all know that better health is less costly than poorer health. So you can think from that perspective. And overuse of services, underuse of services, and also variations is when it doesn't reflect the need of the population, then it's a waste. So we need to consider all this when we make decisions at a patient level and at the level of the healthcare system. So what are these outcomes? Now, patient-reported outcomes are a health report from a patient perspective without any interpretation by the clinicians or anybody else. And it relates to symptoms, functional status, and also the quality of life. So when do we use PROMS, and how do we use PROMS? Basically, PROMS are used for clinician and patient decision making to co-produce care. And Utsala just brought up in the morning about having that safe space. This will actually create a safe space for clinicians as well as patients to talk about and find a commonality about the outcomes they need to achieve together. So it is not the responsibility of the clinician or the responsibility of the patient. Both have to come together and partner with each other to achieve the best health outcome. At the system level, it helps us to benchmark our performance as well. So it enables the clinician, the patients are empowered as well. So from a system perspective, it is important to understand the cost of delivering the outcome. It varies, and also it depends upon the patient needs as well. So the patients, what matters to patient is the results of the treatment. That is what they care about. They don't care about the clinical outcome. They care about whether they are able to go to their job the next day, whether they're able to function, whether they're okay to chew their food. And that is what matters to them. And that is what we need to consider as part of our treatment as well. So we need to think about the determinants when we look at patient situation, because they come to us with extensive social situations that we cannot comprehend or understand without talking to them. So this is just a framework, Fisher and Owen's framework. I'm not going to explain to it, but just understand that there are determinants which impact patients' outcome at an individual level, community level, family level, and a bigger environmental level as well. So it's beyond the remit of healthcare to understand what is happening in patients' life, but we need to integrate while we discuss, have conversation with the patients, we need to make sure that we incorporate it as part of the care planning, and that's very important. So you would have most of the patients talk about or think more about their life, their outcomes, rather than their oral health outcomes. That sits at a very low priority for them, because they are more bothered about their life and their work. So behaviors are not chosen freely, but the social determinants impact on the behavior of the patients. So this also determines how many patients attend on a specific day, or the patients who attend, some of the symptoms they present. So it's important to understand the social situation that shapes patients' behavior. So I just wanted to highlight the difference between patient-reported outcome measures and patient-reported experience measures. They are different. So patient experience measures are more in terms of their interactions with the services. For example, the physical environment. For example, how did they find the consulting room? Was it clean? Did they have to wait? And also, did the oral health professional listen to them? Are their care taken into consideration, needs taken into consideration? So you can see some of the different types of questions that PROMS and PREMS captures. They're very important, okay? And we collect patient-reported experience measures through the patient tracker system. So I just wanted to show you this framework. The Australian Bureau of Statistics undertakes the patient experience survey. Every year it is a population level, and you can see the dimensions that has been identified by some of the consumers. The consumers were consulted extensively to come up with these dimensions that's important to them. So it's at an interpersonal level, clinical and quality, care delivery, and administrative levels. For patients, things like, have I been heard, have my needs been taken care of, are very, very important. And you would have used some of these questions as part of the patient experience tracker. And it is important to ask the right questions to elicit the right response. Otherwise, the data becomes pointless. And we collect more and more and more data, there will be data fatigue. I just wanted to show you some of the results from the patient experience survey that was undertaken by ABS last year, specifically relating to health professionals. What were patients' experience in relation to seeing oral health professionals and how it compares with other professionals? So here are the results. So patients thought that most of the health professionals listen carefully, but as you can see here, dental professionals are more often likely to do that, which is fantastic. So we all have good listening skills, and you can have a look at the third bar there with the gold star. So you can see that we are much ahead of other health professionals in terms of what patients experience, which is great. And this is the where the health professional spends enough time with the patient. And again, in this category, you can see that we exceed other health professionals. So we are much ahead compared to other professionals from a patient viewpoint. And did the health professionals show respect? So again here, oral health professionals are far ahead compared to the other professionals. So you can say that from a patient's viewpoint, we are really, really doing well. And we are not far away from reaching the 100%. So there's always scope for improvement. And you can say that if we can achieve from a patient viewpoint that we are doing really well from their point of view, then why not take it forward and also improve the outcomes for the patients. So it's again partnering and collaborating with patients to understand their needs as well. So we need to give voice to the patients. As I said, patients come from different social circumstances, and we need to understand that. And DHSV, to improve the value of care we provide to the patients and also to improve the outcomes, we conducted the voice of consumer workshops to capture the voices of people who are not in our system. But across Victoria, we went around collecting information. And this project was led by Louis Palmer, DHSV's Chief Experience Officer. And you can see some of the photos there about consumer participation. And they gave us so much of information about their oral health needs, their oral health outcomes achieved, and also what they think the public dental services needs to do to enhance value. And it is very, very insightful for us. And we are using the data to redesign DHSV's service as well. So Louis has extended the invitation to contact her if you need to know more about the project. Her contact details are up on the slides. If you want to be part of it, it's great to collaborate. Okay, it's great to learn from each other. I just wanted to talk about the collaboration with ICHOM. The ICHOM, with the Debs talked about being attending the 2 a.m. telephone conference today that relates to the oral health standard set, which is being developed, and we are using it at DHSV to inform our practice. So ICHOM is a collaboration with a nonprofit organization with members from the Harvard Business School, the Karolinska Institute, and also the Boston Consulting Group. So it took about 2 years, over 2 years for us to develop the standard set. And we have focused specifically on dental caries and periodontal diseases because they are most prevalent diseases. However, the framework for ICHOM can be used for other conditions as well, for example, cancer and other congenital diseases. So this is just a map to show the extensive collaboration network we had as part of the oral health standard set development. So there were participants from about 10 different countries, and also 22 people were involved in the international working group. The FDI World Dental Federation was a part of it. So it was a great collaborative initiative. And also to make sure that the standard set comes from a consumer perspective, and consumer perspectives are involved as part of the standard set. There was a patient advisory group that was formed in the US, and the draft standard set was disseminated to the health practitioners across the globe to understand what do they think about it. And there was a patient validation survey as well, which was undertaken both in the US and Australia. But I'm very pleased to say that we really did very well in Australia, and there were so many consumers. The consumer participation rate was very, very high, and we got so much feedback that we can use as part of our improvement in care delivery. I'm not comparing the consumers between US and Australia, but it is great to see, because without incentive, they have participated, they volunteered their time, and they really provided good feedback. And DHSV appointed 2 consumers, Rebecca Kebery as well as Jackie Gibson, as part of the international working group. And they brought in insightful perspectives that we could never think of. So most of the working group members were clinicians, the researchers, academics, policymakers, who don't have that perspective which the consumer sees from a different angle. And both Jackie and Rebecca debated with world-renowned researchers and academics, and brought them to understand what it matters to patients, and how important it is to simplify the language. And they brought in cultural perspectives as well, and social situations. So I must say that we were really humbled, and we felt very grounded with what Rebecca and Jackie brought to the development of the standard set. So I just wanted to show you the framework we used to develop the standard set. Was the Fda Framework, which involves psychosocial status, physiological functioning, disease and condition status, as well as determinants and moderating factors. So I cannot show you the entire standard set, only because the manuscript is being developed, and it will be published soon, and it will be open for public to use it. Now, DHSV is the very first organization in the world to use the standard set, and we will be informing the international working group as to how it is working at a practical level, and we are testing it at this point of time. So as part of the data collection from the patients, some of the reports from the clinicians, you can see that it is very, very insightful. So the clinicians are using the ICHOM standard set for decision making, and that is very, very important. There is no point collecting data and not using it to make the right decisions for the patients. So clinicians also reported that it is enabling for them to have that conversation with the patients. And the same sentiments were also shared by the evaluators, the researchers as well. So it is great to have the common platform to work on when we collaborate and partner with our patients. And I think Jessica Tran, this morning, spoke to me about one of our patients. Like, she always covers her mouth because she thinks that if she laughs, people will see her as monster. So you can see that, patients have different views of their own health. So it is important for us to incorporate it as part of the care planning. Now, yeah, thank you.
You have 1 minute.
So with 1 minute, what I'm going to do is I'm going to invite Jackie Gibson so that you can hear from her perspective, from first-hand perspective, is what it was to be involved in the international working group, and also what value did she derive being a part of that.
So you are a formidable group to be talking to, and when I accepted this invitation to talk about ICHOMs and my involvement, I perhaps didn't realise the scale, and that's a reminder to me. Being a consumer, I didn't bring slides, but I do have a prop, so wait for it. And I know that I am the only thing between you and lunch at the moment, and I have exactly 3 minutes, so feel free right now, and it will make me feel very comfortable, to look down and check your email on your iPhone. Or Find that perfect meme to send to your friend or auntie or something like that right now. Please do that, because that would make me feel so much better. I wanted to say that I entered into this amazing global, I can imagine communication experts saying, world's first project, not really knowing what I was going to do. It was mentioned at a community reference committee, and we were asked if we thought about it, and I thought, oh, it sounds interesting. Patient outcomes are something that I'm really passionate about. Why? Well, I guess it's one way of me ensuring that when I go to the dentist, that the outcome that I want is actually heard, but it also allows me, as a patient, to hold you, a clinician, accountable. And that we had somewhere along the lines, we had a shared agreement that this is what we're going to do. You might consider that shared decision making. You might think of that as supported decision making because you're an expert, I'm a patient. I was excited, and when I got more and more involved, I learnt a lot. But both Rebecca and I, when we first started, I would like to suggest that we wore our consumer lens. This is our consumer lens. You'll notice that it's shiny and it reflects back. It's also dark, because sometimes our experiences can be pretty dark and we have something to say. And while we brought that perspective to these 2 a.m, 5 a.m, I completely missed the call this morning and slept through my alarm at 10 to 1 in the morning, to which my husband said, could you please turn that alarm off? We learnt a lot. But what we did do was not only bring this lens, but we also brought the lens and learnt about other lenses that were really important. We learnt about different cultures. We learnt that when we all come together, people have different expertise. We learnt about the different country cultures, about how you would talk. We also were very, very, very strong about language. And I think that we spent a lot of time in between international phone call meetings actually talking about language. And what both Rebecca and I did, because it was a fairly big responsibility to say, you are the patient representatives for the entire globe on this committee, that's a fairly big responsibility. So we both worked very hard at making sure we both fed back into our networks and thought very carefully about how we were going to consult, how were we engaging, talking about language. So when they first came up with 125 questions to ask when you had your first, second or third appointment, Rebecca and I were like, let's try and cut that down a bit. Less chatty, more action in my mouth, or at least let's try and establish what I want. So there was a great opportunity of learning. It was collaborative. We were also very well supported. And that was very exciting. But the value it brought to us was that we felt like we were doing something that was really going to have a big impact, and I think that's really important. I think that to find the right consumer who has interest and wants to do something is really important. And each and every one of you probably have a consumer who you could think of doing that with. But you also have to get the right support. We got lots of briefings prior to meetings, thanks to Deb and to other people, about, well, this is what we're going to talk about. And if we didn't know something for which Beck and I would text in the middle of the night, do you know what this is about? And she'd go, no. And I'd go, okay, we'll follow that up. We were really well supported, which I think is one of the reasons why this was such a successful thing. But at the end of the day, the greatest thing for us was seeing this come to fruition to which it is. Everyone else seemed to be very excited about it being published. That was not Beck and I's motivation. We could take that and not really think about it too much, but that was motivation for other people. But it's really exciting to see this come to fruition right now. I don't know if you have a consumer out there who you think would be interested, but you need to support them to do it.